We hit record. All right, there we go. Nobody have anything to say? Wait. All right, tell me what you guys know about COPD.
We have emphysema and chronic bronchitis.
Okay, I like that. Somebody started. Whoo, Lord, I was about to say. All right, emphysema, chronic bronchitis. And remember, you guys had to write this up on the board. So tell me what the signs and symptoms, whether you have both, or actually tell me what the signs and symptoms are for chronic bronchitis. Let's look at it like that.
Productive cough, pursed lip breathing.
Okay, is that for COPD? I mean, is that for chronic bronchitis or for emphysema for the pursed lip breathing?
Chronic bronchitis.
Is she right?
No, emphysema.
Okay. It's emphysema, because I think somebody wrote that up on the board and we corrected that. Are you pulling that from Lippincott?
It was from my notes from class. I just didn't mark it out, I guess.
Okay. Yeah, someone did write pursed lip breathing under COPD, but I said that's actually for emphysema, it's not chronic bronchitis. Chronic bronchitis is more, they are short of breath, but they're not doing pursed lip breathing. Okay. All right, keep going. So since we started with chronic bronchitis, so tell me the rest.
JVD, tripod position.
Okay. So you guys have actually you had the article that you had to read for PNC. Before the article, you kind of went through it on the board. So you should be at this point kind of you should understand COPD relatively well. So besides the fact that they're short of breath, tripod position, what makes chronic bronchitis different from emphysema? Because we did the Venn diagram.
They're the blue bloaters.
What does that mean?
It means that they have signs and symptoms of turning blue in a sense, and also they can lead to right-sided heart failure.
Okay, but why?
They have the excess mucus production as well as the narrowing of the airways with the inflammation. So that's what really causes the heart failure, the right side. It's that pulmonary hypertension.
Okay, so they cough up copious amounts of phlegm. They have a productive cough, right? So they have a productive cough. That mucus is the reason why they are blue, and that's because the gas exchange isn't happening like it should. They do retain CO2. They tend to be more overweight. They do not they do not what is it I wanted to say about that? burn a lot of calories to breathe. So I know that your book talks about more signs and symptoms than what you guys are discussing or mentioning. Because the next piece is, you know, we have that large amount of sputum production, we have shortness of breath upon exertion, we have CO2 retention. And then my next piece is, what would you actually assess? What would be your respiratory assessment related to this condition? What would you be assessing? If you're talking, I can't hear you because you're muted.
One of the using in-situ spirometry,
Okay.
you'll notice a decrease in FEV.
Okay. So their functional expiratory volume would be diminished. Is that what you're saying?
Yes, ma'am.
Okay. So, you know, we would auscultate breath sounds. We would check a pulse ox. So those would be things that we would actually check. You know, can they lie flat, or do they have to be in a high Fowler's or semi Fowler's position? Any other assessments?
Would you do the peak flow meter?
I mean, we could do a peak flow meter to see if they were in the yellow zone. If they were in the yellow zone, how would we treat it? Would that require immediate use of their rescue inhaler of the beta-2 agonist, or what would they need to do?
We probably need to up their dose of long-term muscarinics, anti-muscarinics, and long-term
Okay.
beta agonists.
True, but we're having an acute problem now. So my question is, how do you treat that acute problem?
Short-acting beta agonist, hypertropium atrovent, so short-acting beta agonist,
Okay.
short-acting anti-muscarinic, and if it's acute enough, if in an emergent setting, you would use oral corticosteroids like methylprednisolone,
Okay.
or possibly IV.
So basically, if they were in the red zone.
Correct.
Okay, so how do we calculate what yellow zone and red zone is? What does that mean?
We're talking about peak flow, not spirometry.
Right, we're talking about peak flow. Because spirometry just tells you about saturation of red blood cells, but if your sats are 88%, then you know you have a problem, right? Right?
I was talking more about FEV, not the pulse oximetry.
I get that, but I'm saying for a pulse ox, if it is 90 or less, that would be a big concern, especially for them, because we want their sats to be 92, right?
Yes.
Correct.
Okay, so minus the FEV, let's look at the peak flow meter, since we did talk about getting a peak flow. And so I asked, how would you identify whether they were in the red or yellow zone?
Well, you need to have the baseline of their actual personal best, and then
Okay.
from there, 80% to 50% is yellow, and then below 50% is your red.
Okay, so we'll say their personal best is 300.
So red zone would be 150 or lower.
Okay, so they're at 180, or well, no, 190. We'll say 190. So if it's greater than 150, then we're in the which zone?
Yellow.
We're in the yellow zone. How do we treat that? Because, you know, they really use the peak flow meter for the asthma, but that's fine. But how, you can still use it there. How would you treat it?
I would be more oxygen as needed, titrated to an SpO2 of 92 or above.
Right. We already know yellow means that it's not well controlled. So therefore they would need to use what? Because we got a problem now, so we got to fix it. How are we going to fix it?
An inhaler.
We're going to give them a beta-2 agonist, a short-acting rescue inhaler, however you want to put it, right? So if it was in the red zone, you know, they need to be getting to the emergency room because, you know, they may need more than just the oral corticosteroids. It may need an IV or IV push is what I mean when I say IV. So, you know, there's a difference in treatment. And if you hadn't looked at that asthma plan like I had, you know, kind of talked about before, you may want to lay your eyeballs on it on page 645. So that way you kind of understand what that plan is and what it does and what it doesn't do and what it means. So what type of breath sounds would you expect to hear with someone with COPD, with chronic bronchitis?
You'd expect to hear coarseness due to mucus,
Okay.
wheezing due to narrow airways, and if it's bad enough, diminished breath sounds or absent breath sounds.
Okay, and should we have a silent chest ever?
No.
No, we should never have a silent chest. So we want to hear something, even if it is abnormal. Okay, makes sense? All right, so outside of COPD, what types of, give me some signs and symptoms of, you know, of respiratory, that's respiratory driven, for which you need to respond immediately.
1 to 2 word dyspnea.
Okay, so shortness of breath, okay.
Absent breath sounds.
For sure.
SpO2 lower than 90%.
For sure.
Changes in mental status.
Okay.
Obvious pallor.
Okay.
Or bluish oral mucosa, I guess.
Okay. So what if their respirations were 6?
Oh, you'd need a BVM and breathe
So
for
that
them.
would be some immediate intervention, right?
Yeah.
What about airway obstruction? What kind of sounds would you hear if they have an airway obstruction?
Where is it?
It doesn't matter. It's some.
If it's more upper airway, you expect to hear more stridulous breath sounds.
What's stridulous?
If there's stridor, if there's air moving past the obstruction.
Right.
But if there's no air moving, you're not going to hear air moving.
Right. Okay. So we already talked about absent, or so basically maximum effort but no aeration.
Correct.
Okay. And then if we hear stridor, that lets you know there's a foreign body airway obstruction somewhere. We've already talked about, you know, shortness of breath. What about signs to indicate increased work of breathing? What would those be?
Retraction.
Belly breathing.
So shallow retractions, that would be things that would also require you to act quickly. Okay. So that's just respiratory in general. So if your asthma patient presented that way, your COPD patient presented that way, you need to respond quickly. So it doesn't matter who it is. It's just if they have compromised respirations, then we need to be responding. And that's just not in breathing, it's retractions, it's, you know, abnormal sounds like stridor, because that's indicative of an obstruction. So 1 to 2 word or 1 to 2 syllable dyspnea, those are all things that would be concerning. All right, so say you have, you know, so keep going with our COPD. What else is there about our COPD people?
To look for or to are we in the emergent situation?
To assess. At first, I was just asking what would be their signs and symptoms. And so we kind of talked a little bit about that. if they're having an acute exacerbation, you know, we're going to use a beta 2 agonist. They may have tried to use their rescue inhaler, but we're going to now go to nebulizer treatment, right, to try to open up the airway. Because what's the problem with someone with either COPD or asthma? Is the airway open or is it narrowed?
It's narrow.
It's narrowed. What about bronchiolitis? What's going on there?
It's narrowing of the bronchioles, but also increased mucus production and possible plugging.
Exactly. So, you know, I'm kind of combining all of these so you can see the similarities if you haven't thought of it that way, so you don't stress yourself out like, okay, I got RSV, okay, bronchiolitis, COPD. This way you can, these are all restrictive airway problems. Does that make sense? So in asthma, the whole bronchial tree is gonna narrow, mucus gonna fill in the lumen. And bronchiolitis, then the bronchioles are inflamed, which also decreases the lumen, but the airway lumen is still narrowed. So we have narrowing of the airway that's happening. So you're going to hear wheezes because of that mucus that's actually filling in there, as well as the inflammatory process. So if you can try to here, you can kind of group some things, because although they're different pathways or they have different pathophysiologies, they have some similarities. They're not similar in their like CO2 retention, because in asthma you don't have CO2 retention. Does that make sense? Maybe.
I mean, you can get if the asthma is severe enough, yes, right?
Right, but what I'm saying, but by then it's not that the asthma is severe; it's that you have a mucus plug. So now with that mucus plug, it can now prevent air exchange from happening or gas exchange from happening. So overall, when you have folks with shortness of breath, you want to make sure you do your due diligence in getting a good respiratory assessment. So basically the whole purpose of this was so that you don't go cheesy on the assessment. You just don't listen to breath sounds and then just, you know, check a rate. You need to do a little bit more. So you need to kind of go full regalia and get information about, you know, the distress that they may be experiencing. So just don't say, oh, well, they got, you know, they're short of breath, and just let that go. You know, what else is the issue? Does that make sense? All right, so let's look at emphysema. Emphysema, that will be your pursed lip breathing. Big concern is alveolar collapse, because, you know, they're pursed lip breathing to keep the alveoli open, right? Do they have a ventilation and perfusion mismatch?
No.
No, they don't. So the ventilation and perfusion mismatch is going to be our COPD person. Okay. What if they have a fever, whether it's COPD, whether it's chronic bronchitis or emphysema? What if they have a fever? Is that still their COPD?
No, that's an infectious process.
That's an infectious process. So kind of, you know, having that general understanding about that will be, you know, be helpful for you to kind of navigate between both of the conditions. Again, barrel chest. So that's different than your chronic bronchitis. Usually they do burn up a lot of calories to breathe, so they're much thinner, right? Skin is usually normal for their skin tone, but, you know, they can still have retractions and things of that nature. So when they are distressed, okay? How do we, so are we good about, you know, asthma, you know, the peak flow? We already know the treatment. We understand that, you know, we give medications to open the airway because the airway is narrow, right? So that's why we're giving them the medication. And what if you have a combination you know, medication like for chronic bronchitis? What's the purpose of the combination med? Give me an example based on the article that you read and that the homework assignment you had to do for P&C. It listed some of the common combination medications. So what's the purpose of that?
Usually it's a combination of a LABA and a LAMA, so long-acting beta agonist and a long-acting muscarinic, and the third med is usually an inhaled corticosteroid. Specifically,
Okay. So usually it's a combined. It's usually two. Not which one is a three?
the three is they add an inhaled corticosteroid onto it.
Okay.
It's the article I was reading from the Global COPD Alliance.
No.
Basically,
Freeze.
I know.
Was that the one we assigned?
Yes. Well, it's in our book.
Okay.
It's a reference from our book.
Okay, go ahead. I was like, is that one we said you had to read?
It was okay. So part of the assignment was to have more than just the one reference, and so I used references from our book.
I understand that.
Okay.
I'm just saying what's in your course board. You had to do that for something different, but the one article that you had to read specifically that we talked about in class. Do you remember that one?
I do.
Okay. So they gave you a table, right? And then the table, and I'm not saying that you're wrong. I'm just saying that's something you don't have to stress yourself out in memorizing. Does that make sense?
Yeah.
Okay.
Makes sense.
So that's why I was like, pipe it back. So the one that we discussed in class, so that chart that has the combination, what is it a combination of? And it's usually a duocom. Not duoneb, because that's an A and A. That's Atrovent and albuterol. I'm talking about the one, and you were close to it, but you talked about it with 3 drugs versus 2.
I forgot the specific name of it.
Say that again.
Would it be Symbicort?
What does Symbicort have?
It's a combination of steroid and long-acting bronchodilator.
Okay, so what is the role of a steroid?
To decrease inflammation.
Okay, so basically, if your patient says, what is this, and why do I need to take it? Then you would basically say, hey, this is going to help decrease inflammation. And the other one's going to help keep your bronchi tract or your bronchial tract open. So prevent narrowing of that bronchial tract. But it's usually a steroid and a bronchodilator put together. Does that make sense? Yes. One thing we did not talk about, and I'll just, briefly mention it. I can't remember if we did or not. But, another condition where there's, some shortness of breath, but now the kiddo has a seal barky cough. What is that condition?
Croup.
Okay, so how do we treat that?
Dexamethasone.
Racemic epi.
Before we give meds, what can we do? What can we tell the parents to do?
Cold air.
Say that again.
We always tell them to stick their head in the freezer.
I love it. All right, don't put the baby in the freezer. I don't mind you putting the face in there. That's fine. But, someone feels really, they don't feel comfortable doing that. Then what do we do? What else can we do? Someone said steam. Steam from where? A steamy
hot shower.
From where?
A shower.
Okay. So turn the shower on. Get it super steamy, close the door, then turn the shower off, bring the baby in there. So basically, what is croup?
It's inflammation of the upper airway.
Give me the areas that's inflamed.
It's like laryngeotracheal brake bronchial.
Laryngeotracheal bronchitis. So the larynx, the trachea, and the bronchi, those are the 3 areas that's inflamed. And really, the inflammation is kind of like on the side of the glottic area. So laryngeo. I'm spelling it for you. That's croup. So it could be spelled either way. So with the either that way or just plain CROUP. All right, so long as you understand that. Okay. So we had, tell me about aspiration pneumonia.
It's when liquids are going into the lungs instead of the stomach.
Okay, liquid from where?
It could be from a G tube. It could be from impaired swallowing muscle.
Vomiting.
Okay. What else? So if you have a patient that has an ET tube or has an NG tube, what nursing interventions should you do?
Verification of placement and make sure
Verify
that ET
placement.
tube, you want to make sure that the bulb is fully inflated.
Okay.
Not too inflated that you're cutting off circulation to the surrounding tissue, but inflated enough to stay still.
Okay, so perfect. We want to check residual or we want to check placement. Now we want to check residual too. We want to check placement of the PEG tube or G tube, and we also want to check placement of the ET tube. Make sure that both of those things are where they need to be, right? How do you verify placement for both of those? What is our gold standard?
X-ray.
X-ray. And so for that gastric tube, we want to also check residual. So those are our parameters to make sure, hey, we have things in the right place. Okay, so that way there's no mistake. We can't wag it and say, hey, we thought it was XYZ, and then it turned out, well, yeah, problem, that's not right. So that's the reason why we want to double check that placement and then check residual. Okay. Anything else you can think of for aspiration pneumonia? Because we talked about different ways that it can happen. Laying them on their side if they don't have any C-spine precautions that we need to be worried about, right? Making sure we do auscultate breath sounds front and back and identify if there's any areas of concern. All right, so let's switch to RSV. What is that?
Bronchiolitis.
What does RSV stand for?
Respiratory syncytial virus.
Respiratory syncytial virus. Okay, perfect. Okay, so it is like a form of bronchiolitis. Do we need to do, what's our priority if we have a patient that comes in and we suspect that they have RSV?
Precautions, environmental.
So what
contact and droplet?
Contact and droplet precaution, definitely. Okay, so we want to make sure that we are taking care of that initially. Then we would, treat the individual appropriately, monitoring and assessing all their respiratory status, right? Maybe. Yay, nay?
Sounds appropriate.
I feel like I'm talking to myself. Like, anybody out there? Hello.
I'm just trying not to make chewing noises at you, so I'm muting myself a lot.
Oh, no worries. Okay, so what about, what would be our interventions or our treatments for RSV? What would we do?
Well, just as you stated, first off, ABCs, if airway's messed up or breathing, we want to directly attack that first. And then with that, they have an antiviral med that can be used if it's that severe. And then if the airway is messed up or breathing, we can use albuterol for bronchodilation and then a corticosteroid for long-term effect.
Okay. So when we say ABCs, what part of B do we need? What's our B portion?
Either right.
It's
Right.
breathing, but what are we assessing?
Work of breathing.
Work of breathing, we're assessing breath
Right. If
sounds,
there's
rate
good
and depth.
depth. Sorry.
Okay, we're looking auscultating breath sounds. So of those things, what can we delegate to an LVN?
Can they do the rate,
Which rate?
the respiratory rate?
You mean like get vital signs?
Yes.
Okay, they can take vitals. What else? Because you may work with LVNs and you're going to have to delegate tasks to them. Remember, they can't teach or diagnose, right? They can't titrate drips, but they can auscultate breath sounds. So they can gather data, observe. So that observe will be breath sounds, pulse oximetry. They can administer medication, so they can do that. So for your person that's having, RSV, they can give the aerosolized medication within their scope. Within their scope of practice for an RN that, we can independently complete emission assessments, we can initiate care plans. Can they do care plans?
No.
No, they can't do care plans. But we can, and we can evaluate parents' abilities, like their educational level and skills. So you might want to go back and look at, the roles of delegation that's in your marquee book. So you want to go and check that out. So that way, because NCLEX love to ask questions like, what can you delegate to an unlicensed personnel or unlicensed assistive personnel and to LVNs. So, but they can gather and they can observe and they can take breath sounds and pulse oxes and things of that nature, give medications. Those are things that they can actually do. But they can't do an initial assessment. They what they can do it, but the RN has to come back and verify it. So it's not independent, if that makes sense. All right, so anything else under gas exchange? How would you know, what would be the first sign for an elderly person that they may have pneumonia, a UTI, or urosepsis?
Altered mental status is gonna be your best sign.
Okay, so give me an example of what kind of alteration in mental status that would be.
Confusion.
Like we have
Confusion. So if you have a
Fatigue.
confused as elderly person, that's afebrile. Afebrile means
No
no
fever.
fever.
A
no
fever.
fever. Then you should be thinking pneumonia. You should be thinking UTI or urosepsis, which is basically from a UTI. So they present completely different than, middle age and young adults and kiddos. So they don't rage a fever not for those infections. They actually end up becoming more confused than anything. All right, so gas exchange was our first rodeo ride, I think, that we went through. Then the second concept was immunity, right? No, maybe?
Yes.
Okay. So under immunity, we had ear infection, we had appendicitis, immunizations, and osteomyelitis, correct? And let me know, and think UTI. UTI was another one. So let's start with ear infections, otitis media. What are some signs and symptoms of otitis media?
If it's a child, which it usually is, they'll mess with their ears or tug at their ears.
Okay. So pulling on their ear, are they fussy? Or basically irritable?
Yes.
Okay. Afebrile or febrile?
Could be a mild fever.
Say that again.
Fever, so mild fever.
Okay, so yeah, they'll have a fever. So does the ear infection usually happen by itself, or is there usually a precipitating cause?
It's usually secondary.
What's primary?
URI.
Okay, so an upper respiratory infection. So that usually happens along with this ear infection. So what's your assessment? What do you assess?
The tympanic membrane.
Okay, so you're going to look in the ear, all right? You're going to examine it. What else?
Check to make sure the kid's hydrated.
Okay, check hydration. I like that. We're going to do a temperature. We're going to also take breath sounds since they have an upper respiratory infection. You know, check their nares when we do things like that to make sure, you know, they can breathe through the nares, because they are, you know, that's kind of their primary way of getting that air in, right? How will we treat it? What treatments or interventions would we do for otitis media?
Antipyretics.
Antibiotic.
So acetaminophen, right? Tylenol. We could give ibuprofen at the appropriate age. If it's viral, they probably will not get an antibiotic, but what if it's bacterial?
They would get an oral antibiotic,
Like what?
amoxicillin.
Okay, amoxicillin. All right. So say we have our baby on amoxicillin or our kiddo on amoxicillin for an ear infection. They just completed the medication. What things do you not want to see return?
A fever.
A fever. So if a baby after taking that antibiotic now has a fever, we have a problem. Okay? Because all of that should go away. So it should not even be an issue. Let me mute my phone, so sorry. So if they have repeat infections, what is the physician more likely to do?
Put in tubes.
So put in tubes. Okay. Hold on, sorry about that. Oops. Anything else we want to, what about teaching for home? What do we want to teach them?
Proper feeding positions.
Okay, I like that. What else? I'm so sorry.
Ensure they do the entire antibiotic treatment, not
That
stop
is-
halfway.
Absolutely. Make sure they take all of the medication, because if they don't, then this ear infection is just going to amp right back up. So we're not going to squirrel away any medications. Okay, what else?
Want to make sure they're drinking plenty of fluids.
Okay, like that too. What else? So, you know, to keep the fever down, we want to talk about making sure they give them the Tylenol based on their age or weight.
Their weight.
Their weight. Okay, so what about things at home? What should they avoid?
Sticking stuff in the child's ear.
All right, sticking things in the ear. What else? Because this will also help with prevention. No pacifier. What else? What things can cause them to develop ear infections or upper respiratory infections? What about secondhand smoke?
Yeah, that's bad.
So any baby that has anything respiratory, we should really make sure that that's for asthma too, that in bronchiolitis, that, you know, if folks are smoking at home, they need to stay away from the kiddo, because those things can definitely complicate their healing and bring on the problem in the first place. Okay. All right, so give me an example of active immunity.
Vaccines.
Be specific. Give me a vaccine that provides active immunity, and how would it work?
Influenza. So the live is administered in the body. Your body associates with it, starts attacking it, and then those memory cells are built. So anytime it's reintroduced into the body still has those memory cells that can quickly attack it again.
Okay, so, but you mean for that strain of the flu, right?
Yes, sorry,
Okay.
multiple strains.
All right. Give me an example of passive immunity.
Maternal antibodies.
Okay, maternal antibodies. Okay. Live viruses. I mean, or live vaccines.
MMR, varicella, the rotavirus.
Yep, those are all good ones. All right. So I think next will be UTI. Let's talk about UTIs. What is a UTI? What's the other word for UTI?
Bladder
That's
infections,
cystitis
a lot of people call them.
urethritis.
Say that again. I'm sorry. Cystitis. So what's normally a common cause of why people develop UTIs?
Or wiping the wrong way.
Okay, wiping from front to back or back to front?
Back to front.
Okay, so that's a no-no. What else?
STIs, so sexually transmitted infections.
Okay.
Like not having enough water,
Uh-huh.
drinking a lot of sodas.
Okay. And that also bring on kidney stones, right?
Yes.
Okay.
Catheter use.
All right, catheter use. What about
Being
not wearing cotton?
immunocompromised.
Could that be a cause?
What did you say?
Not wearing cotton underwear, like a cotton crotch underwear.
Oh, yes. And too tight clothing.
Yep, too tight clothing.
Sitting in bubble bath.
Bubble baths. Mm-hmm. What else?
I was gonna say just being a female, just you get them more than males.
True, true. Women do get it more often than guys. That is true.
Obstructions.
Okay. So what would you tell them to do, especially if they're like drinking sodas and things of that nature?
Tell them to drink more water.
Like
Okay,
3 to 4.
besides water. What was that? What works well? What helps the kidneys?
Cranberry juice and vitamin C.
Cranberry juice. What's the vegetable people can eat? It makes the urine smell bad, but it works.
Asparagus.
Asparagus?
Yep, asparagus.
Huh.
Like it smells bad.
Well, only certain people can smell it, though.
Mm-hmm.
It's like a genetic thing, apparently.
I don't know too many people who don't smell it.
I know a few
I've
that
never
had no
smelled
idea
it.
it was a thing.
Oh,
I didn't
wow.
know it's a thing.
Oh, wow. I mean, then you also have stuff like diabetes, pregnancy. Those are also some things that can cause a person to have a UTI, unable to empty the bladder really well, immunosuppression. So those are all things that can, be the cause of a person developing a urinary tract infection. Scented tampons, yep, and pads. So, or those body sprays that people be supposed to be on the body, but not, near certain orifices. So those can also be an issue as well. What signs and symptoms of a UTI? Well, I know you guys got this one.
Gross pee.
Dysuria.
All right, so they can have lower or lower abdominal pain, right?
Yes.
Okay.
Frequency.
Frequency. Dysuria. What's dysuria?
Painful urination.
Painful urination. Turbidity. So the urine would be really turbid, has sediment in it, which that should not be, right? Excuse me.
Right.
Oops. So nocturia, or just, as we said, frequency, they could be incontinent. Hematuria, and then you go to the restroom, but you feel like you don't completely empty it. So like your bladder is still full. and you got to go again. And there's different bacteria, but E. coli is kind of like the #1 most common organism. You can have staph or Klebsiella, Pseudomonas, those are all potentials as well. Diagnostics, what do we want to get?
Urine culture.
Urine analysis and culture. We want both of them. Hopefully they don't have any, pus in urine, pyuria, they don't have any of that. But we can also test for sexually transmitted diseases like chlamydia and gonorrhea, syphilis, and all of those. Not syphilis, I mean herpes. Depending on how bad it is, the urinary tract infection can go all the way up to the renal cortex and medulla area and cause pyelonephritis, which, that would be terrible. You can end up with the abscess. So if it's super bad, then they may end up having to get a CT or maybe get an ultrasound or a kidney scan. So those are all potential things that may be used as the diagnostics. All right, how are we going to treat it? So we did talk about things they could do, teaching them like wiping from front to back and adding cranberry juice, cotton underwear. The one thing we didn't mention is them taking what vitamin?
C.
Vitamin C, how much?
1,000.
1,000 milligrams. So in addition to whichever antibiotic they are prescribed, and they need to take it and complete the course for the respective urinary tract infection. And there's different ones. Some are specific to UTIs that are cephalosporins. Some of them are fluoroquinolones. Some of them are penicillin. Some of them are sulfa-driven, methoxazole. So that would be like your Bactrim. They're going to get the Pyridium. And what is the Pyridium for? What does it do?
It's an antispasmodic.
Antispasmodic or an analgesic agent. So help to relieve the burning and the pain and all of that associated with the urinary tract infection. So just kind of, you got to kind of look a little bit deeper than what you've been looking for your materials. All right. Appendicitis, where does it normally start?
Periumbilical.
Periumbilical radiates to the where?
Right lower quadrant.
Right lower quadrant. Next question is, what kind of pain is that they have in the right lower quadrant? Is that,
Rebound tenderness.
Before that, is it, diffuse pain? Is it intermittent
Sharp and specific.
Pain? Say that again?
Sharp and specific.
It's sharp and specific, but is it continuous, non-continuous, basically persistent? So, what kind of pain do they normally have?
It's non-consistent.
It's actually persistent. So it continues to, it doesn't, it's not like it's persistent mean that it's constant. It doesn't necessarily mean that it's forceful. Does that make sense? So when I say forceful, it's like if a patient was to have like an aortic aneurysm, that pain is really sharp and it feels like it's just ripping the person's insides out. It has that kind of force behind it. Whereas it's persistent. It just means that it's not going away yet. So it's continuous. And what's the pain usually localizes where?
The right lower.
But what's that? McBurney's point. Okay, is rebound tenderness a reliable sign?
No.
No, it is not. Okay, so we can't look at that. We need to look at severity. We need to look at location, things of that nature that would be more reliable for the appendicitis. We're looking at appies. Okay, so something else I want to say about that. We got rebound tenderness. We could have fever. We could have nausea, vomiting, lab values. What labs will we look at?
What cell count?
So get a CBC, white cell count.
H&H.
H&H, we can get that. That's not a problem. We may
12.
end up getting a type and screen for now, unless the kiddo or the person has to go to surgery, then we're going to type and cross, right?
Mm-hmm.
Because we would be looking at potential perforation. We're hoping that doesn't happen. Will this baby get surgery, or will they treat medically first? What?
Treat medically first.
They're going to treat medically first. So they may give them some antibiotics to see how that will work to subside. And then what are some things we could tell them, for their at-home management? I really hope that's water and not pee.
That is water, but how are you hearing that? I thought I muted.
No.
Clearly not, Matt.
We all heard you.
No, I'm doing the dishes right now. I was eating earlier, and now I'm doing the dishes, I swear.
Whatever you say, Matt. This is now on YouTube. We listen to you, pig.
Fantastic.
I'm sorry. Okay, back at the ranch. So I forgot what my question was on the table.
You were hoping that water sound was not pee.
No, that was a distraction. I was like, my original question related to an appy. We talked about treating medically.
Treatment at home.
Yep, taking them home. If they can't treat them medically, then they will take out the appendix. They don't have a problem. How do you know that it's perforated? I think that's where I was going.
The pain goes
No
away.
more pain initially.
No more pain. So the pain stops. So that's how you know. And is that a good thing?
No.
No. The other thing we want to talk to them about at home, this is where I was going, is more fiber in your diet potentially to help facilitate bowel movements in addition to water. So those nutritional components we need to address as well. So we don't want to leave that undone. But our more reliable signs of appendicitis is, is focused on the pain, the severity, the location, and the movement thereof. Those are the things that kind of guide us as real reliable indicators of if a person has appendicitis or not. So they have that periumbilical pain, which is kind of that colicky pain, and then it radiates to the right lower quadrant at McBurney's point. So those are things we would be focused on. All right, so also in this cellulitis, so let's talk a little bit about that. Tell me what do you remember about cellulitis? Carbuncles, furuncles, people that tend to get cellulitis, or what kind of folks?
Tend to have chronic
Yeah.
issues, usually immunocompromised.
Okay, immunocompromised.
Or PVD especially.
What especially?
PVD.
Okay, peripheral vascular disease. Diabetes as well. Right?
Yeah.
Okay.
Totally.
What was that?
I was agreeing because everybody else was agreeing.
Oh, okay. Yep. Woo woo. So, keeping skin hydrated, making sure that if they have, an abrasion of any kind, that they take care of that, because that can actually start the process. So most common bacteria for cellulitis is what?
Staph.
Staph, okay? That is correct. Staph is the most common. So if they're on antibiotics, then again, you know, what if the patient says, well, so if my abrasion heals, do I need to stop taking, can I stop taking my medication? Is that correct?
No.
No. So even if the abrasion heals, they have to complete the whole entire course. So they just can't stop it. Whoop, let me save it for the next time. So we're not going to save anything. All right, let's talk about osteomyelitis. What is osteomyelitis?
It's an infection in the bone.
Okay, so the bone marrow has an infection. Is that good?
Probably not.
Negative. So what usually is the cause of osteomyelitis?
This typically comes from a tissue or a joint that's been infected, and it comes from there.
Okay. So, you know, older folks are at risk for developing osteomyelitis, people with poor nutrition, obesity, impaired immune system, so folks with diabetes, rheumatoid arthritis, and folks that are on immunosuppressive drugs. So you can see it after surgical repair. So if they have a fracture or anything like that, then, you know, it can develop after some type of surgery. And as I said, staph is the most causative agent. Usually we have edema, we have inflammation, we can end up with clots in local vessels, so we can end up with bone necrosis. So, I mean, osteomyelitis is not some sneeze in the breeze. You really do need to be mindful of this person can end up losing a limb if it's not treated appropriately. So the onset's usually pretty sudden. As I said, happens often with clinical or laboratory manifestations like fever, chills, tachycardia, which, you know, those are not normal, right? So what kind of other signs and symptoms, how would the patient tell you, how would you know that this may be potentially an osteomyelitis?
Patient doesn't want to move the affected limb, possibly.
So when they move the limb, they feel like they have like a throbbing or pulsating pain. So with movement, that pulsating pain gets worse when they move the extremity. So, and that can result in pressure, and they can end up with purulent type material or pus drainage, or anything. Those things can happen. So we can get all the way down to the cortex of the bone. So it's painful, swollen, very, very tender, but that's different than compartment syndrome, because compartment syndrome is like you barely touch it and then like the person jumps off the table because the pain is out of proportion to what the injury is. So warm to touch. What would be some assessment findings besides those, or laboratory studies is what I mean?
You're looking for signs. The first concern would be to look for signs and symptoms of shock, because these patients are at high risk of sepsis.
Okay. So usually an early X-ray can demonstrate soft tissue edema. So it takes about 2 to 3 weeks before they get bone necrosis. They can do bone scans. They can do a CBC, get a white cell count, MRI. All of those things are good. But they can also look at an ESR. What is an ESR?
Erythrocyte sedimentation rate.
Yep, erythrocyte sedimentation rate. And that kind of lets you know an infectious process. Wound cultures, blood cultures, because they want to see if this has gone systemic. If, this is why we're getting the blood component. So things we can do to prevent osteomyelitis is if the person currently has an infection, let's not do surgery. So if they have a urinary tract infection, sore throat, or anything like that, making sure that they're very meticulous during the surgery. There's no cross-contamination of anything. Maybe do prophylactic antibiotics beforehand to kind of get the body, kind of prime, for lack of a better word, if they happen to become exposed. Use minimal indwelling catheters as possible. Like urinary catheters and drains, take those out as soon as possible, not leaving those in. So our goal then is to treat the infected process or the infection. So hydration, diet high in vitamins and protein, making sure we correct anemia if that exists because of the infection in the bone marrow. So that will affect the proliferation of those cells. Would we immobilize the extremity?
Yes.
Absolutely. We would immobilize the extremity. And outside of giving the antibiotics, they may have to do some surgical management, debridement, and things like that to help clean it out. And if, they can't, then they may end up doing an amputation, which is something we hope don't happen. Now, how long do you think it takes to cure osteomyelitis? How many days?
4 to 6
More than a
weeks.
couple.
This is long term. So it takes almost a month and a half to treat osteomyelitis. Are we going to keep patients in the hospital for 6 weeks?
Generally, no.
Negative.
Negative. They're going to be out in like 3 to 4 days after the initial insult. So what are some things we need to tell them about home? When they get home, what will be some things that they should be anticipating? Because they're going to, here's the question. They're going to be on antibiotics in the hospital, right? More than likely, what would those antibiotics be? PO or IV?
IV.
It's going to be IV. When they are discharged, what do you think their medication is going to be, PO or IV?
Probably gonna stay IV.
There's going to stay IV. So that line that they're going to go home with is going to be a PICC line. And they're going to have to self-administer that antibiotic. So there's going to be family teaching and education about it, taking or administering the antibiotics as prescribed. So besides the antibiotics, they're going to also be taught to assess the IV site for any signs and symptoms of infiltration, correct? Pain with flushing, redness, induration, swelling, a leak, the catheters leaking. So all of those are signs of infiltration. So that way they just don't keep giving themselves the antibiotics and it goes into their tissue. But they have a long-term regimen. So they're not going to, just because they're discharged, they're not going to go home on PO meds. They're actually going to go home on IV meds for the next several weeks with follow-up with the IND person, which is infectious disease. And they will continue to monitor taking blood work to make sure that the white cell count numbers are going down and not that kind of thing. So those will be some teaching modalities, making sure you use aseptic technique and putting the medications together, connection, flushing the lines, swabbing with alcohol, then, how to connect the pieces together, check for IV site problems. So those be some things that you as a nurse would need to make sure your patient understands. So I wouldn't try to do all of that teaching in one fell swoop. I do a little bit in the morning, a little bit in the afternoon, and a little bit in the evening. So that way they can start thinking about that. What type of nutritional, what should you have them do as far as choices for nutrition?
High protein, high vitamin.
High protein, high vitamin, or high protein and high calorie?
Well, high calorie would help too. But specifically because they're having a bone issue, would we be worried about vitamin D, calcium, and phosphorus?
I mean, they're going to need those too. So they should be to help promote bone, bone strength. So they're going to get rid of the infectious process as well. Oops, wrong thing there. But they need high calorie, high protein for the muscle, right? And vitamins, as we talked about, calcium and vitamin D, maybe some phosphorus, depending on the situation. So, don't forget about those components, because all of those things need to be balanced for your patient. Questions, comments, concerns, issues. I think that rounds up all of the immunity stuff. Would that be a fair assessment? Oh, no, I forgot about trauma, strains and sprains. How could I forget that? All right, so tell me the difference between a strain and a sprain.
Strain involves muscle, while a sprain involves the bone and ligaments.
Okay. Are the signs and symptoms the same, or are they different? Not similar, same.
Similar.
They're similar. What's the difference? We'll start with a strain. So isn't that more of a stretching or tearing of the muscle?
Yes. The strain won't have bruising, is less likely to have bruising at a joint, correct?
Is he right? Because you guys need to know this as well.
Did you say sprain will have bruising?
He said a strain, because that's the only one we're talking about right now. This is muscle fibers are torn. So he's saying that a strain would less likely have bruising.
Yes.
Yes, that's correct.
Okay. All right. And then sprain, that's more of joint instability because the tendon is not stable. Yes or no?
Yes.
Yes.
All right. So how do we treat strains and sprains?
Rice.
Rice.
Not price. I saw that in your book, PRICES, and I said, or CE. I was like, price. P for protection, which would be the immobilization. But yeah, rice, ice, elevate, rest, and compression, which would be the ACE bandage. And should that be above? If you have to immobilize. So say for instance, say even if it wasn't a strain, say if it was a leg injury, then you want to make sure that you support the leg above and below the injury, correct?
Correct.
Okay. So yeah, just make sure when you have folks with strains and sprains that we're thinking about the injuries and how we need to keep them stabilized, but we need to stabilize above and below the injury. And then we would elevate the leg, right? So what if they wanted to sit in a chair? Should we elevate it so that way it doesn't become swollen?
Yes.
Okay. How do you ice it? Is it 20 minutes on, 20 minutes off? Or you just slap a bag of ice on it, come back in an hour, and then put another bag on?
No, on and off.
So 20 on, 20 off. All right.
Preferably you put a thin cloth in. You don't do direct contact with the ice, correct?
That is correct, because then you end up with frozen skin, right?
I mean, that'll help with the pain on the skin, right?
Well, I mean, if it's frozen, then now we have another problem. Just saying.
I was being sarcastic, sorry.
I know. But I'm just saying we have another problem. That's not a good thing. It's like the person who has frozen, like a frozen extremity, and they tell you to go put heat on it or something stupid, like put it under hot water. I'm like, what are you doing? You can't even sense it. You could be burning yourself. How do you know? All right, so I sent out the milestones and assessments, like for human development and things like that. So, don't forget about those things. Like after the baby's born, they should be X amount of weight by X amount of time. So they should be, at least back up to birth weight within 10 days, right? No?
Yes.
Yes.
Oh my gosh. You guys are hurting me, Smalls. Other things to, how do you know a baby's underweight?
If they've lost more than 10%.
So just besides that, I mean, what about if they were 6 months of age? What should their weight be then?
Should be double their birth weight.
And then what about a year out?
Triple.
That's how you know. Okay. Milestones for toddlers. They have separation anxiety, can they express themselves really well, things of that nature. So if you were doing those milestones and assessments, then you should be A-okay. How do they engage children to, like for pain or say if they're going to have a procedure done, or if they want to get information from the kiddo. So say they suspect the kiddo's been abused. What do they normally do to kind of bring that out?
You can use a doll.
So allow the kiddo to play. So, play with the equipment, or if they're trying to figure out they're being abused, and they'll give them a toy to play with to see how they treat it. So they use those types of things to help, facilitate information without saying, hey, did this happen to you? Did this happen to you? Did this happen to you? Play helps with socialization. It helps with emotional outlet, motor skills development. So there's a lot of different things you can get with that. And since they don't really communicate well, it does give you some communicative data that you can actually use that can be tangible to utilize. So just seeing it. Have you guys looked at this stuff, or are you waiting for the weekend?
Can I say yes to both?
All right, older clients, or just a client in general that's has immobility. What's going to be a big concern for them?
Tissue integrity.
Tissue integrity. So a decubitus ulcer. What lab value would give you some information about that? About tissue repair and growth.
Albumin.
Albumin, because it tells you about the proteins that they may have. So, yep, that'll be a good one. What's another thing besides tissue integrity related to what? What would actually be or create their biggest skin integrity problem besides pressure? So say they have an ulcer. What's the
nutrition?
Besides nutrition, what's the next
Moisture.
thing? Moisture. So like incontinence of bowel, bladder, that's going to be, you don't want that to happen, because now it's going to make their situation worse. right? So if they're not mobile, then what should we be doing every 2 hours?
Turning.
We should be turning them from side to side or positioning them in a different position so they're not in the same position all the time. What if they want to sit in the chair? How long should they stay in the chair?
2 hours.
Exactly. So no more than 2 hours. I mean, you guys know these answers. It's like what you're like struggling here.
It felt like a gotcha question.
No, it's not a gotcha. It's just you either know it or you don't know it. You guys did the wound care, right? So you went there.
Yes.
Okay, so
Yeah, we were present.
Oh,
well, that information's testable too. So just FYI. Oh, mercy. All right. I think some of the things that have some of you belly aching over is the acid base. So we'll move on to that. Okay, so if the person has an eating disorder, specifically bulimia. In bulimia, what do they do?
Vomit.
So they basically eat a bunch of crap and then they puke it up, right? How do you know if a person is bulimic?
Their teeth.
usually the first sign is teeth, right?
Exactly. Their teeth are stained and looks terrible. Okay, so if you're vomiting, what acid-base imbalance would you have?
Alkalosis.
Which one, respiratory or metabolic?
Metabolic.
Okay, metabolic. What other electrolyte would you be concerned with?
Potassium.
Potassium. So just don't forget about your imbalances related to losses. Okay, so when you hear COPD, what acid-base imbalance should you be thinking?
Respiratory acidosis.
Respiratory acidosis. Okay, DKA.
Metabolic
Metabolic
acidosis.
Too much Tums.
Metabolic alkalosis.
Boom, done.
Metabolic.
All right. So
Really?
I'm serious. It's just, I mean, some of these you can actually literally think through without stressing yourself all over the place. So
It's too late for that.
Oh, I'm sorry. It's too late for that. All right. All right. Kussmaul's respirations.
Rapid, deep.
Nope. We're still on acid base.
Metabolic acidosis.
Metabolic acidosis. Why? Because it's in DKA. Makes sense? Even if it said coughing up copious amounts of sputum, that would be what?
COPD.
Okay, so what acid-base imbalance would that be?
Respiratory.
Acidosis.
There you go. So it's not just the condition, no, the signs and symptoms related to those, vomiting.
Respiratory alkalosis.
Okay, let's go with narcotic overdose or, heavily sedation or heavily.
Respiratory acidosis.
You see what I'm saying? So some of that stuff you kind of know, you just got to put the pieces together. Does that make sense? What if a person is having they're being on a suction drainage or whatever, and they are the suction is sucking out 300 milliliters every shift.
Metabolic alkalosis.
Look at that. I have to say a word. Simple. So, if I said DKA, give me some ABG numbers that would suffice the acid-base imbalance. And I don't care who does it.
A low pH.
7.3 for pH.
Okay.
And your bicarb would be like 8, about 18. And then CO2 could be dependent on the compensatory actions or not.
So no, we're not talking about compensation, just simple. What would
Oh,
this-
sorry, my bad.
No, you're fine.
CO2 would be elevated.
So what would it be? Give me a number.
Oh, shit.
45.
Okay, 45. It would be normal. Does that make sense? So if I said respiratory acidosis, COPD, give me some numbers that would indicate respiratory acidosis. Go. I don't care who does it.
pH of 7.2.
Okay.
CO2 is 45. 50?
Or at least higher.
Okay, 60. There you go.
What would your bicarb be?
Normal.
Okay, what's
Normal.
25.
Okay, I can take that. So you guys have to be able to not only know what respiratory acidosis look like the pH is high or the CO2 is high and the bicarb is normal. You have to be able to put tangible numbers to it. And, you know, as long as you understand it from a numerical standpoint, I think you got it. I mean, I did it just from condition standpoint. You have to be able to know both ways. So you can't just learn one way, but not learn the other way. Does that make sense? Because if they give you numbers, I don't want you freaking out like, oh my God, you didn't tell me to know the numbers. You have to know the numbers. You have to know the numbers. You have to know the conditions. You have to be able to, you know, think it through. Okay. So just, you know, don't just learn one way of getting to or reaching the same point. So like, you know, if you ask somebody their age, you know, and I may have used this example already in class, what does that age tell you? It gives you some information. So when you're asking for things, just don't be like, oh, okay. The information that you're receiving back means something. So, you know, what can you link that to? Who looked at the what is it? The asthma. There's an asthma process. It's in your RECE book. I don't know if you've been to your RECE book, and it's there for pediatrics that have asthma. There's a specific plan that they put them on. Let's see. There's like a step 1, a step 2, a step 3.
I didn't see that.
I'm sorry.
I didn't look at that.
Oh, okay. So it's the classification for kiddos not taking long-term controlled medications. So, you know, make sure you go to, it's on page 1500, and, you know, understand what that actually means. So if they have mild, persistent, moderate, intermittent, severe, persistent, you know, what would they need to do?
Did you say RECE?
Yep, it's in RICI, RICCI. So how do you treat it? There's a table there, and then it talks about therapeutic regimen and all of that and what you would need to do. So the stepwise approach is actually on 1502. So step 1, step 2, step 3, step 4 kind of gives you the whole shebang-a-lang.
Is it step 1 being the short-acting beta-2 agonist as needed?
And then step 2 would be your low-dose inhaled
Corticosteroid.
corticosteroid that they would have to take daily. So this kind of gives, kind of gives you the information on how they treat it, how they manage it. Okay. So there's like a 6-step process. I'm in the 6-step program.
Yeah.
All right. I know some of you had lab today or skills. So you feel like you're in a better position?
Yes.
Okay.
Relative to what?
Then what you felt before you got on the call?
Oh, in the call, definitely, yeah.
I mean, I would hope.
Oh, yeah, definitely.
I mean, we've gone through every concept. We've done every exemplar. I'm referring you back to the human body because it's so much, but, think about elderly people and, fall risks and, things of that nature that would be a concern. I sent you the milestones and the assessment sheets, and you need to know that anyway. So. As my pooch is over here moaning. I have no idea if you can hear him, but it's pretty loud. All right. So if you don't have anything else you need that's burning that you need to ask me, then we can shut it down. At least you get to bed 30 minutes early or 25.
Thanks for the, you said you emailed us, it was in the email for the milestones?
Right, because Flores got it already.
Okay, good.
So that's how I know that if he got it, then everybody else got it. But it came via email.
Yeah, it's a very passive-aggressive email I sent you.
Fine.
Perfect.
I don't take offense. It wasn't in all caps, so we were good.
Well, I typically write military, and it's very direct and to the point. Like, it probably been in like a 5-word sentence, and I got yelled at a couple weeks ago for doing that to somebody, so I had to change my way of writing.
I'm a native kinetic, and direct is always our plan, so no worries.
All right, noted.
All right. My daughter just zoomed by real quick. All right, guys. Have a good weekend. Try to enjoy some of the weather. Study. We have one more week, then break, but be ready for Tuesday. We are going to hit the ground running on F&E.
Oh, what time is class?
What time?
Let's start. Do you have PNC?
No. I don't
You
think
have
so.
PNC? Do you want to come early or stay late? Did you say thank God? Oh Lord, I'm.
No one said anything about that.
Oh, okay. I'm just gonna leave that be. Do you want to come early or stay late?
I mean, I'm always going to say come early.
Okay.
Early.
Early. All right, let's start at 8:30. Will that work for you? Will that help you navigate through traffic?
Yes.
Or you want to come earlier?
No.
Okay.
Yeah.
I will send out an email to say class will be at 8:30. All right, guys. We'll
Awesome.
see you. I'll see you Monday anyway, but we'll see you then.
Thank you.
You're welcome.
Thank you.
You're welcome. Night night.
Thank you.